बोला है।
Hello. Good afternoon, doctors. Welcome to this webinar on Carbetocin in action from Heathrow. Heathrow Healthcare, as you all know, we have 25 years of excellence. We have got 300 plus products in our portfolio. We have got 36 state-of-art manufacturing facilities and presence in 126 plus countries. We have got 21,000 employees globally, and we are amongst the largest manufacturers of ARV APIs and in the world. We have Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is 360-degree solution provider. We strive to fulfill unmet healthcare needs. We reach out to customer across India when we have got a wide product range encompassing multiple specialties. We are pioneering quality and innovations, and we have the distinction of bringing 4 biosimilar products to market within 5 years of initiation. Carbetocin, doctor, today's topic for webinar is used in the management of used in the prophylactic management of PPH. PPH, we all know, is a condition with potential can lead to disaster, potentially lead to disaster. Although there are a lot of papers and publication and guidelines on use of carbetocin in PPH, we would like to have our own doctor's experience, our own expert experience on PPH and management with carbetocin. For this today, we have got Dr. Sachin Ajmera with us to share his experience and case studies on carbetocin. Dr. Sachin Ajmera is MD, DNP, MNAMS, FCPS, FICMCH, DGO, DFP, DAG. Sir is consultant gynecologist at Disha Hospital. He has won several awards and prizes, including Pramila Bhatia Young Scientist Award, Youth Council Member Award, and Best Management Committee Member Award. Dr. Ajmera is co-editor book on gynecology, Oncology Simplified, a Practical Approach. He has multiple publications to his credit in journals and textbooks too. Welcome, Dr. Sachin, and over the session to you.
Thank you, Dr. Prashant, for that kind introduction. I would like to start with my experience with carbetocin with a few cases that we can just see. Okay, so the first case, she's Mrs. ABC, a 35-year-old. She was a gravida 5 para 4 living 4 with a gestational diabetes mellitus. Dr. Prashant, the previous slide, please. Yeah, with gestational diabetes, she has a known case of bronchial asthma and she was admitted in labor pains. On admission, her vitals were stable. Her abdominal uterus was full term. There was polyhydramnios. They were cephalic, and she was getting regular contractions at around 3 contractions every 10 minutes for lasting for around 40 seconds. Fetal heart sounds were regular. Cervix was 5 centimeters dilated. Presenting part was vertex. Controlled ARM was done. She progressed well and delivered in the next 2 hours. Injection ergometry was given intramuscular. Tablet misoprostol 4 milligrams sublingually was given. However, the bleeding was still significant. Injection tranexamic acid 1 gram was given slow IV along with bimanual uterine massage. Local examination was done to rule out any trauma. And finally, diagnosis of atonic PPH was made. Injection carbetocin was given IV and tonicity of the uterus improved within a few minutes and nothing further was required. Next case, please. Mrs. XYZ, 38-year-old primary gravida with twin gestation, conceived after a donor IVF cycle. She was admitted for elective LSCS at 36.4 weeks. Entire pregnancy was uneventful. She delivered twin girls weighing 2.3 and 2.2 kg. Placenta did not separate on its own and was manually removed. 20 units of oxytocin already given. However, uterus remained atonic. Injection carboprost was given intramuscular. Uterine massage was started. However, uterus remained atonic. Before attempting a B-Lynch procedure, injection carbetocin was tried. Uterus contracted significantly well. B-Lynch procedure, though, was carried out, and rest of the surgery proceeded smoothly without any need for blood transfusion. Post-operative recovery, too, was uneventful. Next slide. Third case, this is Mrs. ABC, 33-year-old, gravida 2, para 1, living 1, with a previous full-term normal delivery. She was admitted in labor. She had a history of PPH in the previous pregnancy, which had necessitated around 6 pints of packed red blood cell transfusion. She was investigated for bleeding disorders, uterine anomalies. However, all her investigations were normal. Previous delivery notes indicated uterine atony as a cause of PPH. In anticipation in this delivery, she was counseled regarding all eventualities vis-a-vis need for blood transfusion, Paniker's cannula, balloon tamponade, operative interventions like B-Lynch, serial vessel occlusions, and even an obstetric hysterectomy. Next So during delivery, assistant gynac, operation theater, anesthetist, cross-match blood, everything was kept ready. Plan in place was to give injection tranexamic acid 1 gram, injection oxytocin to augment labor, injection carbetocin at delivery, intra IV, and tablet misoprostol 400 milligrams sublingual. Second line arrangements were injection methogen, bimanual uterine massage, injection carbocross. Third line was blood transfusion and operative interference. However, to a pleasant surprise, we did not need anything further than carbetocin, reasserting our faith in this molecule. So, learning more about carbetocin. Next slide. So postpartum hemorrhage, we know it's a daunting event. There is a blood loss of at least 500, more than 500 ml following a vaginal delivery and 1000 ml following a cesarean section is what we call as postpartum hemorrhage. It is common and it can occur even in women who are not at risk. I mean, many times we are anticipating a PPH, but nothing happens. And at the moments where we are not anticipating anything, and suddenly, there is postpartum hemorrhage. Next slide, please. So it's a unfortunate yet common event. It is said to be a leading cause of maternal mortality, accounting for nearly about 35% of the maternal deaths. In developing countries, the maternal mortality rate is around 240 per 1 lakh live births compared to 16 in developed countries. But the most common reason for the maternal mortality has been the leading cause is said to be postpartum hemorrhage. Globally, there's an incidence of postpartum hemorrhage is around 14 million women suffer from PPH and reported as 2 to 4% after vaginal delivery and 6% after cesarean. Whereas in India, nearly 38% of maternal deaths are attributed to PPH. 25.7% of global death takes place in India, and two-thirds of this attributed to PPH. And hence, we know that PPH is one thing that we can still conquer in India and reduce, and it can significantly reduce the maternal mortality rate. And hence, we have newer and newer molecules coming for this problem. Next slide, please. So etiology of PPH, generally we know the four T's: the tone, thrombin, trauma, and tissue. Any uterine trauma, injury to the birth canal, retention of placenta, retention of clots, abnormal placentation, coagulopathies. But one of the most common causes, however, still is uterine autonomy, which is also called as inability of the uterus to contract, leading to continuous bleeding. We know that the myometrial muscles are, arranged in such a way that all the blood vessels are occluded whenever the uterus contracts. However, whenever there is uterine autonomy or that muscle tone is lost, what we call as living ligatures, the myometrium of the myometrium part of the uterus is not working and hence leading to a lot of blood loss. Next slide, please. So clinical findings in PPH generally, we classify it into mild, moderate, severe, depending upon the amount of blood loss. And, the blood pressure changes that happen accompanying along with this. However, most of the times we can just see the blood loss and, assess the patient. Can lead to circulatory collapse. The uterus feels flabby, the maternal tachycardia, vaginal bleeding keeps on happening. And, generally don't need much things. So it is there in front of you, when it happens. Next slide. So initial evaluation, once you see that the bleeding is more, the first thing that we need to do is assess the patient status, call for help, check for the tachycardia and the blood pressure, check for all the vital signs. Do a quick examination and rule out any lacerations, hematomas, or any signs of uterine rupture. Do a manual examination to rule out any retained placental tissue. And if possible, can do a bedside ultrasound to check if uterus is dilated or contracted. The status of the uterus, and also or it's not coagulopathy. Okay, most of the times the commonly implicated reason is either trauma or it is either your the tone of the uterus is not good. Next slide, please. Next slide, please, doctor. Yeah. So, uh, can go to the previous slide. Yeah. So approach towards postpartum hemorrhage, you need to rule out if the uterine tone is less. We know going to use uterotonic agents. If there are any tears or trauma, immediately you need to try to repair that. And if there's any retained tissue, again try to do a per vaginal examination. Try to remove any placental bits that are there, or a gentle curettage can be done. Coagulopathy generally is assessed right in the antenatal period. We need to do prothrombin time for all patients. It's ideally should be done in all patients. So the most commonest, again, the implicated reason is a poor uterine tone. Next slide, please. So a rationale for the development of carbetocin, a new heat-stable formulation. Carbetocin is available in a room temperature stable formulation and a convenient vial presentation. It is most of the it needs to be kept in the refrigerator to avoid degradation. So sometimes, if the labor room is, you don't have a refrigerator within the labor room, it takes some efforts to go and get the oxytocin. Heat stable formulation of oxytocin is currently not available. Previously, for carbetocin that was available had to be stored between 2 to 8 degrees. However, now we have got heat stable formulations. In resource poor countries do not always have cold chain transport and storage capabilities. So a need for carbetocin, which is stable at a room temperature, has a shelf life of nearly 24 months and avoids need for cold chain storage and logistics. And it is provided in a vial form. Next slide, please. So uterotonic agents, we know what are the uterotonic agents that are currently available. We have oxytocin, carbetocin, ergometrin, symptometrin, and misoprostol. And these are the molecules that we generally use in the case of PPH. Next slide, please. So oxytocin, we know it's available. We need to give it in an infusion form, and can be given up to 30 to 60 units totally. And but however, we know that oxytocin is associated with hypotension, uh, either when we give it in a bolus or rapidly infuse it, can cause nausea, emesis, and hyponatremia. Oxytocin we know is closely related to antidiuretic hormone. It is both our ADH and oxytocin are your hormones from the posterior pituitary. They both cause antidiuresis, so causes water retention and hyponatremia. Methyl ergometrin needs to be given intramuscular, cannot be given IV, can cause severe vasoconstriction and can have a catastrophic event. So need to counsel your staff, especially that never to be given IV, should be given intramuscular. And it causes severe vasoconstriction, which can lead to hypertension and often causes nausea and emesis. Then we know 15-methyl prostaglandin F2 alpha again needs to be given intramuscular in a dose of 250 microgram, can be repeated every 15 minutes, can be given up to even 4 doses can be given. However, it can cause severe bronchospasm, leads to pulmonary hypertension, nausea, emesis, diarrhea, and flushing. Cannot be given in patients who have got tendency to asthma. Misoprostol, again, a good drug to use. Route of administration can give it rectal, oral, or sublingually, 600 to 1000 milligram in a single dose. However, we know that most of the times with misoprostol, the patient has shivering and fever, and sometimes the shivering is not very controllable. Next slide, please. So, especially when we are expecting that, in patients who can have PPH, older maternal age, overweight, obesity, larger fetal size, this all can lead to dystocia. And when there's dystocia, we give oxytocin for augmentation. Now, in effect, the dystocia by itself can cause postpartum hemorrhage. Next slide, please. So there are several. Oxytocin we know is a naturally occurring hormone, and we would like to replicate or give oxytocin and got minimal side effect as compared to either ergometrin or prostodine or carboprostromethamine. However, there are several threats to the oxytocin quality that occur throughout from manufacturing, procurement, distribution, and storage. If it is not stored well, if it is stored at room temperature, the quality of oxytocin severely deteriorates. And even though you are giving 20 units, maybe the effect would not be seen. Hence, to circumvent this, there is a need of a molecule that is heat stable, can be given easily and stored easily, and the quality should not be an issue. Next slide, please. So herein comes the role of carbetocin. So what is carbetocin per se? It is a synthetic long-acting analog of oxytocin. So it's like an oxytocin agonist drug. So it is used in prevention of PPH due to uterine atony. One vial contains 100 microgram of carbetocin in 1 ml of solution. It has got a long half-life, and there is reduced enzymatic degradation, and hence it acts fast, and the action remains for a longer time as compared to our routine oxytocin. Next slide, please. So, what is the clinical evidence? Now, there has been a WHO champion trial which has concluded that the carbetocin is non-inferior to oxytocin, which means that it is nearly similar. I mean, wherein whatever the effect of oxytocin will be there, carbetocin would give you similar effects. Next slide, please. So this was the champion trial in which the efficacy of carbetocin was compared with oxytocin, and you can see that a blood loss of more than 500 ml or the use of additional uterotonic was required only in 14.5% of patients in which carbetocin was used, as compared to 14.4% in which oxytocin was used. A blood loss of more than 1000 ml, 1.51% in carbetocin compared to 1.45% in oxytocin. So, which means they were nearly similar results. And safety wise, you can see again, carbetocin safety was equivalent to that of oxytocin. Frequency of the expected adverse events did not differ significantly between the two groups. So it was concluded that carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of additional uterotonic agents. Next slide, please. So Cochrane review has said that it had included 11 studies involving nearly 2,635 women. The author concluded for women who undergo cesarean section, carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonics compared to oxytocin. Also, carbetocin is associated with less blood loss compared to symptometry in the prevention of PPH for women who have vaginal deliveries and is associated with a significantly fewer side effects. Next slide, please. So currently, most of the society guidelines do recommend carbetocin as even the first line agent for the PPH prophylaxis. WHO 2018 said only one of the following: oxytocin, carbetocin, misoprostol, ergometrin, or oxytocin and ergometrin fixed dose, that is symptometrin. Canadian guidelines says carbetocin given IV bolus. FIGO guidelines also recommends carbetocin as for PPH management. Germany advises first line treatment for PPH management is carbetocin. France Obs Gynec Society also promotes the use of carbetocin. Next slide, please. Okay, so if there are any
Yeah.
questions.
Yes, sir. We come to our question. The wonderful presentation. We got get insights into. So one thing certain, if there's a atonic pH, carbetocin will work well. Whereas other causes of pH, we have to address the other causes and then maybe use carbetocin or whatever the way it will work.
All right.
So you have been using carbetocin how long, sir?
I've been using carbetocin since nearly when it was launched,
Okay,
and nearly, I guess, 1.5, 2 years we have been
2 years.
using
Yes,
carbetocin.
yes, yes.
Yes.
And
So it has been fantastic, the response. I mean, now the option that we have is, as I said, we have got 5 drugs that we can use commonly in PPH, of which carboprost, I mean, we have nearly given up. I think
oh,
we have hardly used carboprost, must have used hardly 4 or 5 in 4 or 5 patients.
actually.
But with most of the patients now, what we are using is carbetocin. So with carboplus, we had issues. Once we give the injection, patient would have nausea, vomiting. So you have to give additional medicines for that. And many times they already you have given enema, and then they still have loose motions and all that. And so it is not very comfortable. That moment is the enjoyable moment for the patient. Once she's
Absolutely, yes.
delivered,
Yeah, 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 yeah.
give the baby to the
It's
patient,
moment of life. Yeah,
and if she is yeah, this is, I mean, the point that they were waiting for since the last nine
exactly,
months, the entire
exactly. Yeah,
family. And and at that moment, we don't want to spoil that moment by,
absolutely,
with
absolutely.
shivering or loose motions or anything. So, always there was a thing that use a good molecule. So we used to use a lot of oxytocin before. But with oxytocin issues, you need to have the IV running, IV oxytocin also, and then fridge में से लेके आओ. हमारा labor room is slightly
Yeah,
separate, and the refrigerator is not within the labor room. So again, and many times we found that oxytocin doesn't work so well. The effect is not very. So carbetocin has been the go-to molecule, I mean, as of now. And we have had not, I mean, we have hardly had any, side effects or any problems with
correct,
carbetocin.
correct, correct. That's wonderful. And any specific patient profile where you can expect anticipate a PPH?
So PPH, whenever the uterus is over distended, so you have twins, you have polyhydramnios, big babies, wherever the uterus is over distended, there can be PPH.
Yes.
Obese patients, sometimes we cannot assess the uterine tone. These patients are also prone to PPH. And obviously, your most of our IVF patients, we are always worried because sometimes the placenta is densely adherent to the more of placenta
Acha.
accretas and all in such patients is what we expect. And herein also, the chances of PPH are more. But PPH, I don't know. I mean, it is just a mental preparation in these patients that we are mentally prepared. But it doesn't happen in such patients. Generally happens where it is not anticipated.
In fact, you said it, because expect the unexpected is what happens actually.
Yes, very true. Very true.
Yeah. When would you actually prefer carbetocin over oxytocin for prevention of PPH? I mean, you are
So,
already using it,
yeah. So obviously, in patients in whom we are anticipating PPH,
high-risk
definitely,
patients.
yes, all your high risk patients, definitely it would be the first molecule. Now, oxytocin, when we have to give you 4 ampoules, you give, it takes time. Oh, 4 ampoules तोड़ो, load करो,
Yeah,
देना
yeah,
है.
yeah.
So, and again, so carbetocin much more simpler to give single, and now so we have it. It is always prepared. I mean, once the patient's delivering, one of the staff nurses is always preparing all this,
Keeping it.
whatever to be given. Another thing that we use is we use a lot of tranexamic acid also. So even that helps in to a certain extent in preventing of PPH. So
Prefilled
these are the two
carbetocin आता है.
molecules that we use. We give one. Sorry.
Prefilled carbetocin brands are available.
I
Prefilled
didn't get
carbet.
you.
Prefilled
No, no,
carbetocin.
pre-filled are also available. Pre-filled are also
Huh.
available. But then
Exactly.
if it
That's
is
an
in the vial
advantage
form,
again.
yeah, pre-filled are available.
Yeah.
And we also have, a staff nurse who would prepare it. If it is in the
Yeah.
vial form,
Correct.
she would
Correct.
already
Correct.
load it. Once the
Absolutely.
second stage of labor is started.
Can we use carbetocin in case of retained placenta?
Yes, definitely. See, carbetocin is nothing but a long-acting oxytocin. So the
Oxytocin.
question we ask is, do we use oxytocin in retained placenta? Yes.
Yes.
So similarly, we can use carbetocin in retained placenta. So there have been case studies in which carbetocin was given through the umbilical vein.
Umbilical vein.
Yeah, carbetocin was pushed and the placenta had come up. There has been an interesting one paper I read some few months back in which they had they used to routinely give carbetocin. It was in a rural area, so they gave carbetocin, and the placenta somehow they could not deliver the placenta.
Oh, oh,
So they just sutured it back and sent it to a higher center. Once the patient reached the higher center, they found that the placenta was already in the,
oh,
already in the
oh.
vagina.
You know.
So it had already, everything was
Yeah,
done.
yeah,
So
yeah.
definitely, yes, there is no contraindication to use of carbetocin. Now, we don't give ergometry basically. So, but carbetocin is we need to understand the molecule. Carbetocin is nothing but a long-acting oxytocin.
Possibly a faster acting and a longer acting oxytocin.
And yeah, faster and longer acting.
Longer
So it's a
acting.
better oxytocin.
Absolutely.
Yes.
The RH negative mothers.
We'll see again, definitely we can use carbetocin. Again, as we said before, wherever we can use oxytocin, we can use carbetocin. There's no contraindication to the use of carbetocin in RH negative mothers. Previously the thought was, the uterus contracts fast. So once the uterus contracts fast, more of fetal blood would go into
Yes,
the
yes,
maternal
yes.
circulation. So all that concerns were there, but now it is, we give anti-D to all. Okay, and the anti-D that
Okay.
we give is in much more
Enough. Yes.
anticipation to whatever the feto-maternal transfer happens. So there is no contraindication again for the use of carbetocin in RH negative mothers.
I mean, you already answered this. Can your doctor use carbetocin if oxytocin is used for lipids? Where you would prefer IV over IM?
Okay, so IV route we know is it is faster acting. The action should start within 100 to 120 seconds when you're giving it IV. Given IM, the action can take around 3 to 7 minutes to start. So wherever you need the speed of giving carbetocin, you can give it in IV route also. And IM route, so you can use anytime. There's
Yes.
no issue with the IM.
Suppose if the patient is not responding adequately with carbetocin, which additional uterotonics? It would be all, I suppose, other than oxytocin.
So again, you can use, I mean, the mechanism of action, you cannot use oxytocin,
Oxytocin,
obviously,
correct.
because, carbetocin, what we said is a long acting. So it is already acting on the receptors of
And blocking
oxytocin.
the
It has
receptors, yes.
occupied those space of the receptors of oxytocin. So giving further oxytocin is not going to help at all. So the additional nutrotonics that you can use methylergometrin, you can use carboprost, you can use, so the prostaglandins also you can use. So misoprostol again you can use. So everything else can be used. But one thing what I have noticed, if carbetocin doesn't act, nothing acts.
Oh, that bad.
So once if carbetocin is not acting, you should be alert that carbetocin, you have given carbetocin and then it is not acting. Get your second line treatment into motion, which
Right.
may include even the operative interference.
Absolute, absolute. Because life is at stake finally.
Yes,
Advantage of carbetocin over other drugs, oxytocin. Of course, with oxytocin in the interior, it could be a big thing, cold chain, repeated IV infusion, repeated injection.
right.
Yes. Misoprostol, carboprost, and methylergometrin.
So misoprostol, we said that it is does cause patient within say 5-10 minutes, you are given a 600 milligram sublingual dose of misoprostol, which is said to be the fastest acting. You want speed of action in the cases of PPH, and that within 10 to 15 minutes, the patient complains of shivering.
Wow, wow.
There is fever. Okay, so on the fever, it's not that it lasts for some time. It generally can last even for a 1 or 2 hours, post administration of misoprostol. So that is one of the concerns. Carboprost, every time you need to have a history that the patient is not asthmatic.
Asthma, yeah, yeah, yeah.
It can have a serious consequence. If to a asthmatic, if you give carboprost, I mean, you
Prostaglandin,
can.
yes.
Yes, you can. There can be serious consequences. So one thing is you have to be sure your history should be perfect. That patient has never had asthma, and again with carboprost, nausea, vomiting very common, and even loose motions are quite common with carboprost. So again, you know, uh, again we don't want these side effects to happen. Methyl ergometrin, again, it's a good agent, to it good contractions of the uterus, so can be used. But again, methyl ergometrin, we know it should not be given IV at all. Whenever you're
Yeah,
given
yeah.
intramuscular, also, you need to tell your staff
Blood
nurse. I mean,
pressure,
we
yes.
don't give. So, need to ask them to aspirate and see there's no blood, no accidental injection into a blood vessel can be disastrous. Another thing with methyl ergometrin, there is vasoconstriction basically. So vasoconstriction going to lead to hypertension. So in hypertensive patients, borderline hypertensive patients, again, you cannot be using, again, your history should be clear. So it cannot be a blanket regimen. But with carbetocin, all these disadvantages are gone. And, you can blanket, give it to all the patients also. There should not be much of an issue. Okay.
Uh,
However, with carbetocin also, there are certain reports, your blood pressure can raise
okay.
to a certain extent. But again, we have not had, I mean, there's not too much of an issue with carbetocin per se.
Should carbetocin be kept as a reserve drug? I mean, you are already using it as a first line. This question is not really applicable. And why would anyone keep it as a reserve drug looking at the advantage of the drug?
Right.
Yeah, especially side effect. I was wondering whether oxytocin, how common is the ADH side effect with oxytocin?
So, when given in higher doses, oxytocin and ADH, these are both posterior
Correct,
pituitary
correct,
hormones.
correct, correct,
So they are both similar in the actions. They are
correct.
both going to cause antidiuresis. So
Retention
whenever,
of, yeah.
so whenever you're given oxytocin in a large quantity, especially in patients with cesarean, we do notice that after some period of time, the urine gets concentrated.
Oh,
The urine looks dark or sort of. So then we give a rapid IV infusion or sometimes even Lasix because
classics.
it does cause, I mean, it is a very, the effect is of antidiuresis is very much real. especially when you have used, I mean, 20 units, most of the we use 20 units most of the time doesn't cause any problem. But whenever there's PPH and where you have used 40 and 60 units, that is where the problems would start creeping in.
And your one-liner on Carbetocin, take-home message.
So it should, I mean, with its availability and with a heat stable carbetocin, I think it should be the first line for management of PPH now. I mean, in the current scenario of what we have. And again, carbetocin safety, efficacy wise, safety and tolerability is, as comparable to any other euthyrotoxics, or even much better than as compared to other euthyrotoxics. So I think carbetocin should be the first line of management. And as I said, if carbetocin doesn't act, I mean, your antennas should be up and, start acting fast, because then nothing may help.
And it was lovely, I mean, these insights, practical insights are always anytime better than the theoretical ones, and
Uh,
coming from our own doctor and our own patients, which is the
right.
whole objective of this webinar, our participant doctors. I'm sure they must have benefited. And I
Sure.
thank all the participating doctors who took time from the schedule and attended this meeting. Thanks, marketing team, for conceptualizing this webinar. Thank you, field team Hitro, for coordinating. And last but not the least, thank you, IT team Jayant, for your continuous backup support. Sir, thank you once again. It was a pleasure listening to your meeting. Thank you.
Thank you. Thank you, Dr. Prasan. My
Wish you a
pleasure.
very pleasant evening.
Thank
Signing
you
off.
so much.
Thank you. Shall we stop, Jayant? Leave? Yeah, we can leave, sir.
Okay. Thank you.
Yeah, thank you.